Hello.
Can you hear us and can you see
Yes.
us there in the auditorium?
Good morning, Ajit. I am Dr. Behel from AIMS, New Delhi. And am I audible? Ajit?
Yeah. Morning,
Good
Dr.
morning.
Behel. We have Dr. Alan, myself doing the first case. Morning.
Great.
There's a little difficulty in hearing you. Maybe one mic would be better.
Okay. I have with me Dr. Trehan and others will be joining shortly. Dr. Prashad is there, so other panelists are expected to join. So can you tell us what is in store for us today? Am I audible?
Go ahead.
Okay.
Ajit, this is Vijay Tren. Is this
you're
audible to you?
Sir. Good morning to all. This is, we have Mr. You're audible, Dr. Vijay Tren, sir.
Yeah, thank you. Good
So
morning.
we have a 69-year-old gentleman who is a diabetic. Good morning. He is a diabetic, not a hypertensive. He had inferior MI and was lysed with STK on 13th of December 2016. Coronary angiogram done showed a borderline mid-LAD disease and a tight lesion at the RCA bifurcation.
Can you see the angiograms now? Can you put up the angiograms as of today?
We can.
Okay. Can you see the left coronary angiogram?
Yes, we can.
Okay, okay. So this gentleman has a LAD which is about 60% stenosis in the mid segment. You can see the diffusely diseased LAD in the mid segment, and the PDA you can see is fills retrograde. Can I see the next left picture? And you can see that the circumflex is non-dominant. Again, the LAD lesion is borderline and is in the mid-segment. There is some osteal LAD disease, but not significant. And this is the right, which is, you can see, is a critical bifurcation stenosis involving the PDA-PLV bifurcation, a 1-1-1 Medina classification bifurcation. You can see there's calcification in the right, and there's a diffusely diseased PDA origin and a tight curved lesion in the PLV at the bifurcation.
So we have a bifurcation.
Okay, so our strategy to start off, myself and Dr. Alan, was, and before we get your strategy, I would ask Dr. Alan to think what we would do first, and then maybe take the feedback from the audience. So Dr. Alan, please go ahead.
Yeah, I mean, we thought it's a bifurcation lesion with a bifurcation angle of nearly 90 degrees, and the side branch looks like more than 2 millimeters. 2 millimeters. The side branch also has a long tight lesion in the proximal segment extending for more than 15 to 20 millimeters. So two-stent technique would be the better choice for this. And with the angulation being favorable, a T stenting or a provisional T would have been the choice. So now we would like to get the feedback from the panel as to what they would have done.
So it is T or tap? You'll have a T or tap?
That was our strategy, tap or T.
Okay. So,
Tap would be first.
okay. So two-stent strategy.
Is there any other
with the-
different point of view from the audience?
No, but if you have a possibility of having a tap, I think this lesion is not very long, and osteum is not terribly bad. I think it's still about 70%, but many times you can just get away by a single stent in these cases, and the only way of getting away with single stent is that if you have a cutting balloon, if you can cut into the PLB, then the osteal modification may be better, and the snow plowing effect after the stenting into the side branch may be less. So it is possible that you get away with single stent.
I
And,
thought
and in case,
what he meant was going with a stent from right to PLV and treating PD as a tap. Is it right?
you want, Ajit, you want which vessel you want to make as a main and which one as a side branch? If you want to make the PLB as main,
I think that the PLV is the bigger vessel. Yeah, it's the main vessel, and the PDA is a smaller vessel. You can also see that the PDA was filling retrograde from the left, so I would be more protecting the PLV as my primary vessel and the PDA as a secondary vessel.
because PLB may be smaller in diameter, but since it gives a lot of septals and is longish in diameter, I think hemodynamically, as well as area being supplied, I think PD has to be prioritized.
But I think in this you can do any of the
Okay.
techniques you like.
Okay, so
whatever you wish.
what we yeah, correct. So our plan was to wire both the vessels and then do a pre-dilatation and do an IVUS to the main vessel and see how it is, and then plan what next. And so we can just show what happened. So as we were waiting, there
Sure.
was a little bit delay, so we thought we'll go ahead and do the wiring. So see what happened.
Sure. I
So can you go ahead?
Yes, sure.
So this is the first wire, which is a cyan blue, which went into the PLV pretty quickly. And can you freeze that? Can you freeze that, please? Yeah, and you can see now there's a 90-degree takeoff of the PDA
Yes.
from the RCA, and there is a calcific small spur just before the very small spur before the bifurcation. And you can also see, if you can play that carefully down, that the PDA is diffusely diseased after the origin right up to about 10 millimeters. Okay, so can we have the next shot now? Now, you understand, while the wire was just about getting into that lesion, and this was, we first tried with a Gallia wire, and then, which is a cruiser, which is a new wire of theirs. And then when we found difficulty, we shifted on to a hydrophilic wire, which is basically the whisper. And as we were trying to go through that, you can see the difficulty we had because of the 90-degree bend. The patient developed ST elevation. And you can see now that there is a flap arisen, possibly because of the wire manipulation at the bifurcation,
Yes.
with a doubt of possibly intramural hematoma. So this happened about, say, 8 to 10 minutes ago, and the patient had chest pain and ST changes in the inferior lateral leads. And you can see that the PDA flow is okay, but the PLV flow is significantly compromised.
சரி ஓகே சொல்றேன்.
So this is what happened. So we had to electively change our strategy
இதோ கொஞ்ச நேரத்துல வைக்கிறோம்.
to pre-dilate the lesion so that we get flow down the PLV. And we sequentially dilated it with a 1.510 and a 210. And you can see that still there's a dye hang up in the distal PLV. So can we go to the next shot, please? So this is how it looked after the balloon dilatation with the 2 millimeter. We have some flow. The ST started coming down. The PDA flow is still there, but the PLV flow is still slow. You can see that. He already on board is aspirin Plavix, 7,500 heparin, and we gave Necorandil and nitroglycerine down the coronary before taking the shot. So what would be, obviously, the decision now is to bail out the PLV quickly, because that's the most important thing here to do, because obviously the PDA is collateralized and collateralized, and you can see that the PLV is the cause of the problems right now. Yeah, and we had to stent the whole thing very quickly so as to get the patient hemodynamically better. So you know, this is what happened. So the strategy completely changed from elective procedure to a semi-urgent procedure with a bailout for the PLV.
Sure.
Any thoughts on this?
See, one option in this situation is that, see, many times the stiffer part of the previous wire, which you have already wired into the PLB, that causes a sort of hindrance to the wire which tries to get into the PD. And many times pulling the PLB wire, just keeping the soft part across the bifurcation so that you are not losing the excess, that can change the anatomy, because if you look at it, it's all become straightened. And pulling the PLB wire with the soft part at bifurcation at times permit you to get into PD. Or else, like in this case, the entry into PLB was looking easy.
I completely agree with that, and I think
and the other thing is that, like in this case, the entry into PLB was looking easier, and the PLB is not all that bad. The endeavor would have been better to first wire PD and then PLB. But now I think with the PLB flow going down, I think the situation is different.
But once you stent the
I think that's
RCA
a
to
very
PLV, what
good
we will do for
suggestion, Dr.
PD?
Trehan, that we possibly could have tried the PDA first, wiring, and then the PLV, but there's a downside to the whole thing, that if you dissected that at that point of time, then you would maybe lose access, though the PLV is a little relatively easier to cross. The other option which we tried was to pull the soft wire. We changed the, we in fact did what you said, that we pulled back the Xion blue and put the soft wire across to try to cross, but it was not. And unfortunately, in a few minutes, we got a flap up, which had to be now fixed.
Like going ahead now, what is your strategy? You will stent the
Is there any other
RCA
thoughts from the panel?
Now, what is your planning?
Yeah,
You are
so
putting
my
a stent from
strategy right
RCA
now, and we discussed it.
PLV and then try for the PD, or?
Yeah, PLV.
Okay.
Yeah, well, I thought the first thing to do is to fix the PLV, because that's the hemodynamic problem.
And then look at
review the hemodynamics. If the patient's chest pain comes down and there is no problem, then take the call. So that's what we did. So unfortunately, we couldn't wait for all this, and because all this happened in a hurry. So this is a 275-33 Zions Alpine stent. And you can see the dissection stroke intramural hematoma there, sitting there at which is expanding. So we didn't take any weight. We didn't even do an IVUS before doing this, because we wanted to fix this quick. And in this story, we should remember that you need to pull back the stent much before the hematoma, so that you have coverage of both the proximal and the distal hematoma. Okay, so this is a 275-33 Zions Alpine going up. And immediately after that, you can see that the flows in the PLV are maintained. The PDA is still not occluded. The ST settled down, and there is no more chest pain. So clearly, the problem was the PLV, very, very clearly, you know. And the PDA you can see it's filling antegrade, and is also there's some collateral filling backwards on the left. So I'm now less concerned about the PDA, and I will be trying my best to fix the PLV right. Okay, so I will show you, so we went up with a pot in the proximal with a 3O to keep that PDA origin open, and then post-dilated the entire stent. And you can see now that, can we show the, first the stent boost, or what we call as this stent whiz from the G lab. So can we show that, please? The lower, and you can see that even after the first spot, you can see the proximal stent is underdone with a 3 at 20. So this is one useful technology you can use in a hurry when you can't use imaging procedures because of, you know, you have a patient having problems in the lab, which you can use it with the angiogram so that you can quickly know whether we have done the stent right or not. Can you see that in the auditorium?
We can.
Okay. Okay, so we went up with a 3O up to about 24 atmospheres, and show me the picture of the angiogram again now.
Angio next.
Next angio, please. Okay, just to, so that we have a little time, well, we just post-dilated, and then I will show you the IVUS picture. So can you now show the IVUS post-dilatation to show? And I will have Dr. Vijay Kumar to tell us about the IVUS. Can we have a mic for him, please? Okay, so maybe he doesn't have a mic, so I will read it for you. Can you see the IVUS on the screen now?
We can.
And, okay, so we need to show a bigger picture of the IVUS and the smaller everything else. So this is the distal RCA, and this you can see there is some distal disease. It's about a 3 millimeter vessel, and now you can see the stent coming in. This is the Alpine 275, which has been blown to a 3020. And you can see that it's nice and round, well expanded, no malapposition. And Vijay, can you just show where the side branch comes? Just freeze that if you can. And you can see, you can see that clearly at around the 6 to 7 o'clock position.
Yep.
That's the side branch coming in there. And you can see, and you can see from approximately 7 to about 11, it would have been much easier to show it with a OCT, but you can see a huge dissection, which is arising from, say, 7 to about 3. I can see that. And there's no clear intramural hematoma here, but I think possibly the stent has stacked that back. But clearly a large dissection, which has been tacked back with the stent. And you can see now the proximal area, which also has some disease in the RCA. It's a diffuse disease, right? And can we have some areas there, please?
7 millimeters.
Yeah.
FFR will be.
So the areas Vijay has just calculated, it's around 7. So with a more or less it's 7 proximal and 7 mid and distal. So we were okay with that. Yeah. So this is, so 7.1. Can you see that picture?
Yeah. So having done that, now what next? Will you
So
try to
basically-
salvage the PD or leave it?
Yes. Yeah. Well, two options. We looked at the clinical picture. The patient has no pain, absolutely, once the PLV was fixed. And it was a difficult entry, so I don't want to disturb the stent. My option was to not do anything further at this point of time. Can you show the last picture? There was significantly lower flows in the PDA, and you can see, but absolutely no symptoms, no ECG change. And the patient is completely comfortable after the stenting after the post-dilatation. So my issue is that the PLV was the problem right now, and trying to do too much, and you can see there's also another smaller PDA apart from the first PDA. There are two PDAs. And if you have no symptoms and the patient is comfortable and he has a good collaterals, I wouldn't waste my time trying to chase it and try to make a complicated procedure more complicated by trying to go through the strut and doing few things. If the patient was symptomatic, if his hemodynamics were not good, the STs were up, I would definitely chase that down. But in this scenario, my interest is not to make this more complicated at this point of time, because the patient is completely asymptomatic, heart rate is comfortable, the blood pressure is normal, and the ECGs are normal. Your take on this, Trehan and Gahal?
I think better is enemy of good. We should remember that. We'll go along with you, and it's fine.
One thing which could have been done in this scenario is that what is known as the pot is usually helping you to get into the side branch, where at the same time, once you inflate a balloon, higher size, little higher pressures, across or near the bifurcation, then whatever small little flow was there in the PD is likely to become much less than that. So what I do is, what I call it is a pre-pot. Pre-pot is that you take a larger balloon, means larger in diameter, shorter in length, and inflate it short of the bifurcation, so that the stent which you showed on your stent boost, which was underexpanded, so that if you want to visit this stent and get into the side branch, you don't get outside the stent. So you do what is known as a pre-pot. That means you inflate, you do a pot proximal to the bifurcation. And then with a pre-pot, without disturbing the carina, when the flow was still there, then you try a slip wire into the side branch. That kind of a technique works more often than fails. Now that we didn't try it and side branch is gone, I think we'll have to go by symptom guided or ischemia guided, and in case the patient demands a procedure to be done, then I think he is an ideal case for a stent assisted reverse cart, because he already have a stent there. To go retro for the in future, you
So
already
what
have
we
a
will
stent.
do is, we have an interesting case in the other lab. Dr. Shivakumar
Okay.
is doing a paravalvular leak, and he's ready. So I'm going to go to the other lab. Our plan is to do an FFR to the LAD. We will come back in the last 10 minutes to show you the FFR to the LAD.
Great,
in the
Ajit.
meantime.
Great. Thanks for the interesting case. Are we audible?
Hello?
Yes, Ajit. What have you
I'm
done?
audible.
Okay.
Are you audible?
Yes,
I
yes,
can hear
yes.
you. Can you hear us?
Yes. Eagerly awaiting what you have done.
Okay. Okay, so now we're going to very quickly show you the LAD. It's a very straightforward FFR study, but for the purpose of all the people who are not used to FFR, I will just show you some basic steps, and then Dr. Alan will explain to you. So before we go, that's the angiogram. Can you see the angiogram on the screen?
We
the
can.
first angiogram.
We can.
Okay, the first angiogram shows a borderline LAD lesion in the proximal and mid segment, and this is where we are going to check the FFR. So can we show the FFR wire? This is the St. Jude wire. Can you show it here? Okay, so this has a switch which is on the bottom. There's a small sort of rotator for the wire, and the wire is put into a sheath. This is the pressure wire Eris, which is from St. Jude. So the first thing that you do is you will flush the catheter.
Ajit,
so
we
that
have
there is
5 minutes
no,
of transmission
problem with
left.
the-
Ajit,
So you,
we have 4 to 5
I
minutes
will
of
just quickly
transmission
go
left.
through it.
Yes.
Well, it's,
Okay.
yeah, okay. Okay, so we'll go through this quickly. So once you flush it, then you pull the wire back and the connector back in, and then you switch on the machine. Just for the steps, you put this green light comes on, and then you advance the wire into the LED. Now, can you go to the screen? Show me the angiogram picture, please, the FFR wire. Yeah, so that's it. Can you see it there on the screen?
Yes.
Yeah, okay, so the wire, the distal radiopaque part has to be just outside the guiding catheter. Remember, the guiding catheter has to be into the left main, except in cases with left main nostril stenosis. You need to flush all the dye out and with saline so that there's no guide dye in. And this is the time you equalize the wire. So can you show now the equalized pressure? So can you see on the right side of the screen the PDPA after equalization is 1. Can you see that?
Yes.
So that's the first step that you do. Okay, then what you do is you move the wire. Can you see the next angiogram, please?
We can't see the FFR screen very well.
Across the lesion, there are 2 lesions in the...
FFR, show the FFR screen big.
Yeah, we can see the screen, but we don't see anything on the screen. We can see the data of the patient coming.
Okay, the FFR wire, unfortunately, I'm not sure what we can do about that, but I think the FFR, let me just tell you that the FFR at rest after the wire is down is 0.91.
But this wire is better than the previous
So
wire.
then you go to the adenosine, which you give it. Yeah.
You
and
prefer-
then you go to the post-adenosine 140 micron. So
You prefer intracoronary over intravenous?
With after 140 mics of adenosine, it came to 0.81. Yeah, we always give routinely intravenous only. And the FFR was 0.81, and then we did a pullback also. This is a pullback, and the pullback also you can see.
No, once your
0.942
once your wire as distal shows you a
to normal at 1. So there
PDPA
was no
0.81,
drift
I
also.
don't think pullback will be.
Yeah. Yeah.
yeah.
Yeah.
So basically, this is a negative FFR to the LED. So just to show you, just for the purpose of people who don't use FFR, just to show you how to demonstrate it, it's very important to do the procedure properly. Otherwise, you'll get a lot of wrong results. So we have to pull back at the end of this day and show that there is no drift. So end of the day, this patient does not require anything for the LAD, and we leave him with the PCI to the RCA. Does Shiva want to show anything more there? Is there
No,
anything, Shiva, you want to show?
he has
Then
already...
we can conclude it in a minute
and
on
this-
the other side.
And this 0.81 FFR is with the collateral flow to RCA. So once RCA is fed antegrately, this FFR will climb up. The value which is coming as 0.81 is with the PD getting
Okay,
retrograde
just to
from L.
thank all the... That's correct.
Yeah.
That's correct. So it's even more significantly non-significant. So basically,
Sodium nitroprusside.
thank you very much for giving us the
Thank you, Ajit.
opportunity to beam into Tanjore. I'd like to thank Dr. Keshavamurthy and thank Dr. Alan, sisters, Dr. Mr. Benjamin, and everybody from Frederick and everybody in the CAT lab for helping us for this transmission. Thank you very much.
Great job done, Ajit. Thanks.
Thank you.